Hello everyone, my name is Przemysław Zabel and I would like to tell you something about navigated OCT microsecond pulsed laser therapy in the treatment of retinal diseases. For more than a half century, ophthalmologists have relied on light to treat retinal disease. After observing the effects of a solar eclipse on patients' retinas, Gerhard Meyer-Schwickerath investigated using natural sunlight to treat retinal disease, first successfully using the technique in 1949 to perform a retinal coagulation. Unfortunately, the technique was limited by weather conditions, the lightly exposure time required, and the constantly changing angle of the sun in the sky. The first retinal photocoagulation using an artificial light source was performed in 1956 by Meyer-Schwickerath using a xenon arc lamp of his design that was built in cooperation with the Zeiss company. For years, retinal laser treatment has been associated with thermal destruction of retinal tissue. The advent of modern lasers has diminished the role of laser photocoagulation complications by more precise delivery of the power to the tissue. However, the principle of thermal destruction of the retinal cells remained. In recent years, it has been observed that scarring does not seem to be necessary to obtain a therapeutic effect. The insertion of laser power on the RPE not only results in tissue scarring, but also in the production of heat shock proteins by surrounding the laser spot surviving tissue. This stress-related response of the retinal tissue results in the immunomodulation of cell function, triggers repair process, and then normalizes the production of certain cytokines which reduce chronic inflammation that was previously present in the retina. Microsecond pulse laser therapy triggers a stress response and induces beneficial intracellular biological factors that have anti-angiogenic and regenerative process without destroying tissues, as in the case of laser photocoagulation. On this slide you can see the difference in the effect on the eye tissues between the micropulse and continuous wave modes. In the micropulse mode, laser impact is divided into many repetitive short impulses measured in microseconds, between which there are intervals and enable retinal tissue to cool down. The effective time of work the laser is called a duty cycle, and in retinal diseases is empirically set at 5% with 0.2 seconds duration of the exposure envelope. Using the Navilas Prime device, we conducted research to comparatively evaluate the effectiveness of navigated OCT micropulse laser therapy in the treatment of retinal diseases associated with the accumulation of subretinal and intraretinal fluid. We inducted patients with sub- and intraretinal fluid in the study, dividing into them two study groups. The inclusion criteria were intraretinal or subretinal fluid in the macular area lasting for at least 3 weeks, and no significant media opacity that prevents a clear view of the fundus. The exclusion criteria were disorders of the vitreoretinal interface, condition after vitrectomy or anti-VEGF injections, and features of neovascularization in OCT angiography. 17 patients with subretinal fluid and 22 patients with intraretinal fluid were enrolled in the study. The group of patients with intraretinal fluid was significantly older, while best-corrected visual acuity did not differ significantly. All patients underwent an ophthalmological examination, which included assessment of best-corrected visual acuity using Snellen charts, examination of the anterior and posterior segments using a slit lamp, spectral domain OCT and angio OCT. All patients had repeated examination 5-8 weeks after laser therapy. All laser treatments were performed with Navilas Laser System Prime. I would like to show you the video with the microsecond pulsed laser therapy procedure. After obtaining OCT photos, the images are uploaded to the laser to precisely select the area with fluid so that targeted laser therapy can be performed. Now I set the spacing between spots to 0. The spot size in this case was 260 micrometer, power 300 milliwatts, and exposure time 200 milliseconds. Depending on the size of the edema and the size of the spot, I determine the laser power, which is usually between 240–300 milliwatts. And after marking the laser spots on the obtained retinal image, we can start the therapy. Okay, and now we can start. The table below shows the laser parameters that did not differ between the groups. Analysis of retinal structural results of the retina in eyes with intraretinal fluid showed significant improvement in each parameters. The average retinal thickness in the fovea before laser treatment was 417.1 micrometer, but at the first follow-up it decreased and amounted to 350.5 micrometer. The illustration below the table shows that improvement was not achieved only in two cases, number 4 and number 9. A similar situation occurred in the group of patients with subretinal fluid because after laser therapy, each tested parameter improved. It is worth noting that in this group, the initial thickness of the retina in fovea was found to be significantly lower than in intraretinal fluid group, but in the case of maximum retinal thickness in the macula, no difference were found between the groups. In this group of patients, no response to therapy was observed only in the first case from the presented graphic. In the remaining case, the improvement was significant. Comparative analysis of the structural results of the studied groups after microsecond pulsed laser therapy showed that patients with subretinal fluid respond better to the laser, obtaining significantly better structural results than patients with intraretinal fluid. The greatest differences between the studied groups concerned the area of maximum retinal thickness in the macula, where the group of patients with intraretinal fluid improved by 72.7 micrometer and the group with subretinal fluid by 105.5 micrometer. Finally, I would like to present three cases. The first one is a 50-year-old female patient who was referred for consultation due to persistent cystoid macular edema due to uveitis. Before microsecond pulse laser therapy, we can see significant macular edema and best corrected visual acuity 0.7. 696 spots were delivered using 200 milliwatts of laser power with a duration of 200 milliseconds at 5% duty cycle and a spot size of 210 micrometer. After 6 weeks, the macular edema subsided and visual acuity improvement to 1.0 on Snellen charts. The second case presents a 39-year-old male with chronic central serous chorioretinopathy in right eye, was treated with local and general medications and unnavigated OCT microsecond pulse laser therapy without significant effects. Before therapy, the fluid was located in the foveal area and above the optic disc. 762 spots were delivered to the retina in the fluid area with a 260 milliwatts laser power, achieving complete absorption over the optic disc and almost complete absorption in the foveal area, improving the visual acuity from 0.6 to 0.9. The last case presents a 76-year-old diabetic patient treated with oral drugs and insulin for 23 years. Due to general contraindications, instead of anti-VEGF injection, microsecond pulse laser therapy was used, which resulted in improvement of structural parameters and visual acuity. In this case, 689 spots were delivered using 260 milliwatts of laser power with a duration of 200 milliseconds at 5% duty cycle, and a spot size was 210 micrometer. We can also see the improvement of visual acuity from 0.4 to 0.7 of Snellen charts. To sum up, navigated OCT microsecond pulse laser therapy to the area of retinal edema is effective in treating cases with both subretinal fluid and intraretinal fluid, even when the retinal thickness exceeds 400 micrometer. RPE stimulation with microsecond pulse laser therapy is more effective when fluid accumulates under the sensory retina than when intraretinal fluid is present. Using retinal thickness maps from OCT, we can perform very precise subthreshold laser therapy of the retina in a selected area, while sparing places where no pathology is detected. Finally, the images below shows a patient with optical disc pit maculopathy. After navigated OCT microsecond pulse laser therapy, we see the absorption of the subretinal fluid after 7 weeks. Thank you very much for your attention.